I'm going to try and focus this guide on breast cancer very much to things that may be useful to you as general practitioners. But really just to start first with a few obvious statistics, and I'm sure all of you are well aware that breast cancer is the most common cancer diagnosed in women in Australia. And in fact, there'll be nearly 20,000 cases in Australia of breast cancer this year, most in women, although around 150 or 160 will be in men. And of course, that means that here in WA, we will see around 2,000 new cases of breast cancer this year. And breast cancer is also the second most common cause of cancer death, only outstripped by lung cancer, unfortunately. Not a great statistic to have. But breast cancer remains a killer of somewhere in the region of 700 or 800 women each year from breast cancer. And we still have a way to go, despite the fact the survival rate, as you can see, is clearly improving. And our current WA 5-year survival rate, and by 5 years, that's really where we're measuring it in trials, is over 93%. So it has improved dramatically. You can also see that this is an incidence curve of the most common ages that women present with breast cancer. And although you can see that the commonest age group for developing breast cancer are women in their early 60s, it is a disease that can affect women at any age. And we do see some women even in their early 20s with breast cancer. And that'll be important when we talk a bit later about signs and symptoms of the disease. You can see this chart of mortality, and I think this is a real success rate. What we've managed to do is decrease the death rate from breast cancer over the last 25 years by about 25%. And that remarkable achievement has largely been due to better treatments, but to an extent it's also been because of earlier diagnosis with things such as mammographic screening. And again, we'll come on to talk a bit about that later on in this talk. This is some data from our Department of Health from the WA Cancer Registry, looking at something we call relative survival by age group. And this shows, these are figures up until 2014, and what relative survival is includes other causes of death. So this is survival of patients from breast cancer relative to dying of other causes. And you can see that it's actually very good at 92%. But interestingly, that the group who do best are women in their middle years. And we think that probably younger women do slightly worse because they have more aggressive tumours, whereas older women do slightly worse, probably because they're somewhat undertreated. They're not as likely to receive chemotherapy and may present later. And just to confirm this data at a single institution, this was looked at some years ago. These were some survival statistics from Royal Perth Hospital. And really the thing I want to point out to you is that if women present very early with breast cancer, either with stage 1 disease, that is tumours less than 2 centimetres, or indeed stage 0, which is ductal carcinoma in situ or DCIS, they can expect to have an extremely similar survival to women who've never had breast cancer. However, with women presenting at a later stage disease, unfortunately that drops right down to 50% or even lower for women who present with metastatic disease. So I thought we'd talk first about some of the risk factors for breast cancer, because when you see a patient who comes to your surgery concerned about her risk, it's important to be able to identify all of those for a woman. And I've divided them here into 3 different areas. The first are things we call lifestyle factors. And as I'm sure you're well aware, many cancers and indeed many other chronic diseases have similar lifestyle factors in common. Excess alcohol consumption, and that means more than 1 standard unit a day for women, overweight and obesity, and physical inactivity. So they're all things that we can really talk to women about, not only lowering their risk of cardiovascular disease, but lowering their risk of breast cancer by addressing those lifestyle risk factors. Environmental factors are probably less common and less easy to really define. By radiation, we largely mean mantle irradiation for Hodgkin's lymphoma rather than background irradiation, although it may be that excessive medical irradiation may increase risk of a number of cancers and possibly breast cancer. There's a little bit of information around occupation, particularly around shift work, but that risk is fairly low. And then interestingly, biomedical factors. Clearly, as we've talked about, increasing age and being a woman is the most significant risk factor for breast cancer. I'm going to talk a little bit more detail today about 2 of those other risk factors. One is a family history and the other is breast density. But I'd like to now just point you to this chart here, because this gives you some idea of what the actual, what that risk is, what the quantitative risk is. And these are relative risk increases for these various factors that we've talked about. So you can see that some of the hormonal factors, such as taking menopausal hormone replacement therapy, or indeed having an endogenous, very long period cycles with an early menarche and a late menopause, will increase your relative risk of getting breast cancer a small amount by about 0.3, 1.3, 1.4 increased relative risk. So if you look overall, that is actually a relatively small lifetime increased risk, similar to alcohol consumption and obesity. But once you start looking at a strong family history or very dense breast tissue on a mammogram, you can see that those risks increase significantly. And equally, we've added in there whether the patient's got a past history of an abnormal breast lesion that's not cancer, but is an atypical lesion, or what we now would call lobular neoplasia, or LCIS. And those also significantly increase your risk. And if we think that overall a woman has around an 8% chance of having breast cancer in her lifetime, you can see that if that's increased by 4 or 5 times, then that's a significant increased risk. I've put as the title of this, are these competing risks additive? And that's something we actually can't answer at the moment. But I think when you are taking a history from a patient, if they're ticking off 4 or 5 of those different risk factors, then that's probably a significant increased risk. So we'll start thinking about family history. And by that, I'm really talking about a family history where there are multiple relatives with young onset breast cancer, or ovarian cancer, which we know in terms of the BRCA1 and 2 genes are related to each other, or a family history of bilateral breast cancer in a younger woman, or male breast cancer in the family, a family obviously that has a known mutation running through the family. And we also know that Ashkenazi Jewish people have a much higher risk of carrying BRCA1 or 2 mutations. Now, it is important to remember that the vast majority of breast cancers are spontaneous, so they're not associated with a known inheritable genetic mutation. Only about 5% of breast cancers have a known inheritable genetic mutation, but many other patients will have a family history of breast cancer. And how common is that? Well, these really strong family histories where there are multiple breast cancers in the family, or ovarian cancer, and therefore the woman is potentially at high risk, and by that we define over 3 times the population risk, that's actually around 100,000 Australian women. So that's a lot of people undiagnosed out in our community with potentially a high risk of breast cancer. There are many, many more women, however, who we would put at moderate risk because of a smaller family history, perhaps just having an aunt with breast cancer, or a grandmother or a mother at an elderly age. And these women are probably more difficult in some ways for you to deal with than the very high risk women. We know that families where there are multiple cases of breast and ovarian cancer, those families have a 30% chance of having a germline mutation, and therefore it's well worth us knowing a bit more about it. So how would you as a GP go about assessing a risk? Well, I think it is important, as I said at the beginning, to really take a good history of all those risk factors, because some of them may add up together and some of them may be modifiable. In terms of the family history, we usually put things into 3 categories, and I've put up the website there of Cancer Australia, who have a reasonably easy to use online tool that you can use to divide women into potentially high risk of breast and ovarian cancer, or category 3, having more than 3 times the underlying risk, moderately increased risk, or at or slightly above population risk. And I'm just going to talk in a bit more detail about what we do about the top 2 categories. Before I go on to do that, I just wanted to point out one other resource that people are finding very useful, and that's a relatively new website developed by the Peter Mac, by the Genetic Services Group at the Peter Mac, called iPrevent. And this can actually be done by the patient herself, with or without the help of a doctor or indeed a clinic nurse. And this will give a patient an idea of what she is likely to have in terms of risk over the next 10 years and what she can do about it in terms of reducing her risk. So what can we do about women at high risk? Well, if we genuinely think they're high risk because they have multiple family members, for example, with breast and ovarian cancer, this is the only group where we would teach women how to do a regular self-examination and suggest that she does that on a monthly basis. Otherwise, as you're probably aware, we encourage women to do something that we would call breast awareness, but not self-examination. For all women, we would give them that healthy lifestyle advice. But for the high-risk women, I think it is worth referring them for further assessment to a high-risk service. And what happens there is that they will be seen usually every 6 months for a clinical examination by a specialist. That may be a breast physician, that may be a surgeon, it may even be a genetic clinic at times. Those women are eligible for an annual MRI screen from around the age of 30 or 5 years younger, 5 years before the youngest diagnosis of cancer in the family. And traditionally, we've always added a mammogram to that, but we're beginning to think now that really with our really very good MRIs, we are able to just do the MRI, and of course that saves on radiation. The MRI for screening, do be aware, is only eligible for high-risk women who have been assessed as that and can only be ordered by a specialist. Paul Cohn is going to talk to you in a little while about ovarian cancer, but ovarian surveillance is absolutely useless in these women, unfortunately, so that needs to be sorted out by a gynae oncologist. And there are some prevention strategies that we might think about, such as chemo prevention using tamoxifen, trials of some new drugs, and we have a new trial opening soon for patients with BRCA1 mutations using infactinozumab, or surgery, which I'll mention a bit more in a moment. That much larger group of moderate risk women are actually harder to deal with, I think. Healthy lifestyle advice is clear, and it may be that for some you want to refer them to a high-risk service where an annual mammogram and an annual clinical breast examination will occur. But those women do not have increased risk of ovarian cancer. As a surgeon, I get referred many of these women, and we do talk about prophylactic mastectomy. And it's interesting, I often get asked, well, who do you actually offer that to? Well, if the patient has a known genetic mutation, such as a BRCA mutation, we would offer it to her. But for some women with a strong family history, even if we can't find a mutation, prophylactic mastectomy after much counselling, after seeing a psychologist, may be the appropriate thing to do. And in fact, now there is a role for testing, increasingly testing, genetic testing women who've not had breast cancer. And genetic testing is becoming easier to sort out, but I think it's important that somebody sees a specialist before they do this and not just go online and get a genetic test. There are other things that come into the decision around prophylactic mastectomy that I've put up there that we may discuss in more detail in the questions. So who should you refer, and where should you refer these patients to that you're worried about their risk? Well, if they're a known gene carrier or a relative of a known gene carrier, please refer them up. If they're at high risk because you've looked at their family history, multiple young women in the family have had breast cancer, please refer them. Selected women at medium risk, we're happy to see and at least sort out whether or not they are at high risk. Some of those will simply be the worried well and may be reassured and sent back to a normal screening program, 2-yearly mammography. And those who previously had breast cancer, you may worry much more about those carrying a genetic risk. Where do you refer people to? Well, there's a familial cancer service at King Edward Memorial Hospital. It's a public service. They're happy to triage letters that you get, and often they will then refer the patients onto our surveillance clinics first. They will offer a genetic testing service, but not a surveillance and ongoing follow-up service. There's also private genetic counselling at the Women's Centre in Subicao. And the high-risk surveillance services exist in the public service at Royal Perth, Fiona, Stanley and Sir Charles Gardner Hospital. We're happy to see patients at St John of God in Subicao Hospital, and a number of breast surgeons have a particular interest in this area as well. And there's lots of support for women at high risk. This is just showing you a few of those support services that are available, including the Menopause Symptoms After Cancer Clinic, which I think Paul will talk about a bit later when he talks about gynecological malignancies. Now moving on to a different subject entirely, and that's breast cancer screening. And I'm sure everybody here is well aware of the National Breast Screening Programme. It's been running now for nearly 30 years in this country. Eligible women are between 50 and 74, and they're invited off the electoral register every 2 years for a free mammogram. The idea of breast screen is once we get to the point where a diagnosis has been made by a lesion that needs further investigation with surgery, the GP is run by the service, and you, with the patient, can decide where to go. So the service does not go all the way through to managing the breast cancer, although obviously if the patient has come to a breast assessment clinic at one of the public hospitals, she's welcome to stay there for her treatment. It's also important to remember that women over 40 and over 75 can ring up and ask to have a free mammogram. Despite what I think is a great service and a really excellent quality control service, we only have around a 55% participation rate, and we would encourage you to encourage your patients to come along to this. And I've just shown a picture of the bus there up in the Kimberleys, and it's obviously been in the Kimberleys recently because I've had 3 patients at Royal Perth this morning operating on who were screen detected from the Kimberley, but it's a great service. But one of the things that we have found after our 30 years of breast screening mammography surveillance is that a number of women coming for mammograms are found to have dense breasts. Around 40% of women, in fact, have some degree of breast density, and around 5% will have very dense breasts. And this is a double whammy, really, because one, having a lot of white on the mammogram, very dense breasts, makes mammographic surveillance much more difficult. We know it makes it harder to pick up cancers, but it also increases the absolute risk of developing a cancer, and particularly an aggressive breast cancer, in fact. So nowadays, our service here in WA will actually send patients out a letter, and to yourselves as well, saying that they have a breast density. How Breast Screen WA measure density, however, is a difficult subject because it is measured on a BIRADS report, which is essentially the 2 radiologists looking at the mammogram and deciding what the density looks like. We know that there are probably more accurate and reproducible measures, but they're expensive. Some private practices have that, such as the Volpara test, and it may be you find it useful to use those practices. But the real issue, I think, is that when a patient gets this dense breast letter, what's she told? Well, she's told to go and see you guys, go and see the GP. And what do you do about it? Well, that's actually quite difficult because there's actually not a lot of evidence about what we do for those women. So we know the mammogram's not as sensitive, and we know they have an increased risk of breast cancer. So what are we going to do? Well, probably it is worth looking at all of their other risk factors that we've already talked about, and it may be that many of those women would benefit from an additional ultrasound, but remembering that in the screening setting, that ultrasound is not Medicare rebatable. They will have to pay for it. One important point, I think, is that these women don't need more frequent screening mammograms, so sending them for a mammogram every year has not been shown to be useful. The problem is, of course, that it's very easy to say we can get more ultrasounds or perhaps even an MRI for these women, but we know that this supplemental screening leads to more biopsies. It probably leads to more diagnosis of things that don't need treatment, and it certainly leads to more anxiety and an increase of women coming to me as a surgeon saying that they want to have prophylactic surgery. So things have not really been sorted out in that space yet, and we're still doing research in this area. So I'll move on now to breast cancer per se. And I briefly just wanted to go over our definitions of breast cancer. So this is early breast cancer. This is cancer localized to the breast and all the lymph nodes, where the aim of treatment is cure. And around 5% of patients who present with newly diagnosed breast cancer present with advanced breast cancer, which secondary, metastatic, stage 4, they're all the same things. And that's essentially where cancer is spread beyond the breast and the lymph nodes to more distant parts of the body, or sometimes fixed in the breast, and where it's a locally advanced disease. And largely we think that this is not incurable, although I have to say with modern treatments now, many of these patients can live for many years and perhaps even a near normal lifespan and have a chronic illness rather than a terminal illness. When we think about breast cancer after it's diagnosed, these are the things that we think about that guide treatment. So the pathology report, looking at tumour factors, the size, the lymph node involvement, the grade of the tumour, the receptors of the tumour, perhaps other issues such as the turnover, which is Ki67, how fast it's growing, whether it's infiltrated with lymphocytes, and we're increasingly beginning to rely on molecular tests such as Oncotype DX. But we also look at patient factors, their age, comorbidity, patient choice, and perhaps even social and financial factors. For yourselves as GPs, however, what really matters is to be able to pick up a breast cancer early, and so recognizing the signs and symptoms of a breast cancer as opposed to the signs and symptoms of benign disease. The commonest sign and symptom of a breast cancer is a lump in the breast or axilla, and pain is important. About 5% of breast cancers are painful, and a lump and pain coming together that is non-cyclical in a postmenopausal woman immediately raises red flags. But breast cancer can also not uncommonly present with changes in the nipple, retraction, scaliness, Paget's disease, which looks like eczema of the nipple, redness of the breast, or discharge from the nipple, which can be underlying DCIS, or a subtle change in the shape or appearance of the breast, particularly when a woman raises her arms with the dimpling of the breast. Cancer Council WA have produced this really nice little measure that helps you really flag up, is it red, very high risk, or is it white, very unlikely, giving you a positive predictive value of what these different signs and symptoms are, so you can try and work out who you should refer on. So you can clearly see that a younger woman with breast pain only has a very unlikely chance of that being breast cancer, whereas an older woman with a breast lump and or pain, that is a much more likely to be breast cancer. The key, I think, for you guys, though, is investigating the symptoms, and the triple test remains the mainstay of how we diagnose breast cancer. And the triple test means your findings on clinical examination, imaging with mammography and or ultrasound, and a non-excisional biopsy. So most likely nowadays a core biopsy. And the vital thing about a triple test, if a woman comes with symptoms, is to perform these 3 tests and that they all have to correlate. So if one of them is different, it doesn't seem to correlate, and that could be any of them, then the woman fails the triple test and needs referring for further investigation. There's a nice handout from Cancer Australia that really gives you this in more detail, and I'd urge any of you to go online and get this if you're interested. And really anybody who fails the triple test should be urgently referred to a breast assessment clinic. So what breast imaging should you actually be doing? Well, if the patient is over 35, best to always start with a screening with a mammogram. But at any age, if you think it is a breast cancer, even if it's a 22-year-old with a highly suspicious lump, please get a mammogram. If they've had one within the last 12 months, for example, through breast screen, you probably don't need to repeat that unless it's suspicious. So if it's suspicious and they had a mammogram 6 months ago, repeat the mammogram. An ultrasound should probably be added at any age, and it's certainly very useful to clarify the mammographic lesion. It's not a good screening tool, but if the woman is under 35, if it's not a suspicious lesion, an ultrasound alone is probably reasonable. Significant lesion, age over 36, always get both. The pathology report that comes back to you from the biopsy is important as well, because it may just report hyperplasia, in which case that is benign, but anything with atypia needs further investigations, and obviously atypia can go on to progress to cancer. Where should you refer for the imaging? Well, I think it is important to consider what imaging practice you're referring to, and somebody with breast expertise I think is important, and unfortunately I've seen too many patients who go to breast imagers who don't have a lot of breast expertise, and therefore things can be missed. It's also important and on us to ensure that appropriate imaging is done, so that we ask for the mammogram and the ultrasound if that's what we want, and to have it done on both sides. And we talked about the non-surgical biopsy. I think nowadays a core biopsy is probably best for virtually everybody to make a diagnosis. Where should you refer in terms of breast assessment clinics? Well, in the public, there are breast assessment clinics at all of the public hospitals, including in Bunbury in the country, and all of those are quite happy to do the full workup. So if you're suspicious, even if you haven't done a full workup, we're happy to do all of that and come up with a multidisciplinary management plan. If you're going to be referring to a breast surgeon outside that, it's great either publicly or privately that it can be an accredited breast surgeon, and Breast Surgeons, which is our Breast Surgical Society website, have a list of those accredited breast surgeons. And really the key is that they're related to a multidisciplinary team, and therefore management can be instituted if cancer is diagnosed. Now, for the last couple of minutes, I think we've got time for a minute or two just to do a couple of quick case studies, perhaps. So this is a 40-year-old who presents with a 2-centimetre non-tender lump in the upper outer quadrant of the left breast. She's got no family history, no other risk factors, apart from the fact that she's nulliparous, and you examine her, she's got a lump only. So if we look at those Cancer Council guidelines, this is a very low risk of being cancer, but nevertheless it needs investigation. So she has a mammogram and an ultrasound, and these are suspicious of cancer. The practice does an ultrasound-guided core biopsy, and it comes back as benign. And here you can see the mammogram and the ultrasound, something that looks highly suspicious, a mass with calcifications, an abnormal mass on ultrasound. What are you going to do? Well, this lady has failed the triple test because even though her core biopsy is benign, that looks suspicious to you. So she needs to be referred on to a breast assessment clinic for further action. Second case, this is a 69-year-old lady who presents with a few months' history of a nipple retraction. And it's the slit-like nipple retraction that you can see in the first picture there. She's got no other symptoms past medical history, but she's a smoker. Now, if you again look at your Cancer Council little cheat sheet, because of her age, and this is nipple retraction, it's about 12% risk of getting cancer. So even though you don't think it's cancer, you think it may be ductectasia because it's slit-like and she's a smoker, this needs further investigation. We do that initially with a mammogram and an ultrasound, and again, this looks benign. She's got dilated ducts with debris, but things still don't quite stack up in terms of the triple test because she has an abnormal symptom. And here's her mammogram showing widespread benign-looking calcification. So action, she needs to have further investigation, almost certainly by a breast assessment clinic, although this one is a little bit less clear. So I'll stop there and hopefully there'll be a few questions. Thank you.
Thanks, Christobel. That was fantastic. So we do have a few minutes for questions. So we have a comment box on your screen. So if you have any questions, please do type them on the chat box. There's one that's come in from Rosalie. It says that if there are symptoms, we need a diagnostic mammogram. I thought this was different from a screening mammogram. Please advise.
It absolutely is, and I'm sorry I didn't make that clearer, Rosalie. So screening mammography is for asymptomatic women. So our breast screen program, Breast Screen WA, just offers mammography to women who don't have symptoms. Saying that, I have to say that particularly in very remote areas, if the van is up, for example, in the Kimberley, they are willing to do mammograms occasionally on women with symptoms. So screening mammograms are for asymptomatic women. If a woman has a symptom, she has a symptomatic mammogram, which does then have a Medicare rebate, for example, and needs to be done through either one of the public services or through a private radiology practice. You're quite right.
Another question from Paula. She's asking how to assess approach breastfeeding women. Breasts are all lumpy.
Yes, well, I think it's really important going back to the fact that breast cancer can occur at any age, is that any breast symptom needs to be taken seriously. And we know that women who present with pregnancy and lactational related breast cancer often present quite late because either themselves or their midwives or doctors have not really taken so much notice of the breast symptom. So a woman, whether she's pregnant, lactating, or anything else, if she has a persisting symptom and a lump, it still needs investigation. And you can still do almost exactly the same investigation. So an ultrasound would be your first point of call, but a mammogram can be done. Even in a pregnant woman with shielding, a mammogram can be done. It can be done during lactation as well. You try and get them to empty the breast first to get a better picture. It's difficult to see things, but we can pick up cancers. And if necessary, a core biopsy needs to be done. So you still, if you're concerned about it, if it's a persisting mass in a breast, even in a pregnant lactating woman, it needs proper investigation, please.
We've got two talks in the next hour, one on cervical cancer prevention and then a talk on ovarian cancer. And I thought what we'd do is have questions for each talk at the end of each talk. So we'll have a few minutes for questions after the first talk and then again after the second. So the learning objectives for the cervical cancer prevention talk are to understand the epidemiology of cervix cancer, both in Australia but also worldwide, understanding the pathobiology of the disease, knowing its main risk factors, knowing which ones are potentially modifiable, and really having an understanding of the prevention strategies. So cervical cancer globally is a huge problem. It's the fourth most common cancer in women. It accounts for over 300,000 deaths per year, and last year was estimated to be nearly 600,000 new diagnoses. And 90% of the diagnoses and deaths occur in low and middle income countries, particularly in sub-Saharan Africa and South and Central America. We're very fortunate in Australia that we were one of the first countries in the world to have an organised screening program, which has led to a substantial reduction in the incidence and mortality from the disease. HPV, particularly subtypes 16 and 18, account for over 2/3 of all cervix cancers. But HPV infection is very common, and obviously only a very small minority of women go on to develop cervix cancer. In Australia, which is a stark contrast, there are less than 1,000 new diagnoses a year. And the estimated number of deaths in 2018, and these are figures from Cancer Australia, were 258 women. The chance of surviving at least 5 years from a cervical cancer is very good, and that this is partly because of the screening program, which is identifying more cases at an early stage. But even for locally advanced disease, which is confined to the pelvis or pelvic lymph nodes, concurrent chemoradiotherapy is associated with significant cure rates. It's estimated that there are over 3,000 women in Australia who are living following a diagnosis of cervical cancer, and if you assume that we have about 10% of the national population in WA, that's about 300 women. So the risk factors, I'm sure you all know this, but just really to emphasize that it's all about high-risk subtypes of human papillomavirus infection. They cause about 99% of all cervical cancer. And so the risk factors for cervix cancer are those factors which are associated with infection with these high-risk HPV subtypes. So we all know early age of sexual debut, multiple partners, high-risk partners, history of sexually transmitted infections, HPV-related vulval and vaginal dysplasia because it's a field change affecting the genital tract, also anal HPV infection. Importantly, smoking. So smoking confers twice the risk of cervical precancer, and more importantly, this is one of the few modifiable risk factors. So if we can get a woman to cease smoking, that will actually lower her risk back to the population levels. Immune suppression is an important group of women, so we're seeing more women with chronic HPV infection on immunosuppressants, or women that have had renal transplants, and women with cystic fibrosis with lung transplants living into the 4th and 5th decades. They're high risk for chronic HPV infection and cervical cancer. Probably most important, and I've got a couple of slides that keep re-emphasizing this, and I make no apology, is the fact that 80% of all women in Australia who are diagnosed with cervix cancer have either never had a cervical screening test or who are lapsed screeners. They're not compliant with the recommended screening interval. And therefore that's something we can actually make a difference as healthcare providers and impacting further on reducing cervical cancer incidence and mortality. The final one here on this slide is increasing age, because it's chronic HPV infection, failure to clear the virus, and that becomes more of a risk with advancing years. So just a slide really about the pathophysiology of cervical cancer. That is, I'm sure you all recognize, as a normal appearing cervix on a speculum examination. And 5 weeks after infection with an HPV subtype, this is an electron micrograph, which we can just point out here. So that's actually showing virions, which are particles that contain millions and millions of viruses. This is the colposcopic appearance, so acetic acid or vinegar applied on the cervix under magnification. And this is exactly what an acute infection with an HPV subtype looks like. The HPV virus has 9 genes. It's a very, very simple organism. E is early expressed and L is expressed later. And most women, 98% of women following this acute infection over about 12 to 18 months will clear the viral infection. And if you perform a colposcopy in those women from about a year to 18 months, then you'll go back to a normal appearance. A very small minority may, over time, progress to high-grade squamous intraepithelial lesions. This is a different colposcopic appearance. We can see some abnormal vessels here, denser staining. And this is a cervical cytology, an old pap smear, showing that we've got highly abnormal cells. If we look in the slide here, this is a normal appearing cell with a small nucleus. Here we see large abnormal nuclei taking up the nuclear stain because you've got a lot more mitoses and cell division going on, which you can see on the slide. Even here, a proportion will actually be cleared over time. But women who don't clear the infection over a decade or more, 15 years, will risk progression to cancer. It's actually still a minority. Only about 10 to 15% of women over 10 years will go on from a high-grade squamous intraepithelial lesion or dysplastic lesion to cervical cancer. Obviously, the 2 points of prevention will be the screening, formerly pap smear screening, and I'll talk more about the new program, the renewal, later on in the talk. But if we diagnose this pre-invasive lesion through screening, then we have an opportunity to treat and to cure the woman long before it ever has an opportunity to progress to malignancy. And of course, primary prevention, which is preventing the HPV infection in the first place, and that's what vaccination is all about, and that's what I'm going to talk about next. So vaccination started, I'm sure you'll remember, 12 years ago, 2007, we were the first country in the world to have a formalized vaccination program. And then in 2013, initially the program was in girls. In 2013, it was rolled out to boys. Historically, we've had rates of vaccine coverage varying from state to state, and I'll show you some figures shortly, between 75 and 80%, which is good. And then secondary prevention is all around screening, and I'm not going to dwell on this because we cover it in subsequent slides. Just to say, this is the impact on cervical cancer incidence solely because of screening. And prior to the early 1990s, when screening actually was introduced, it came in about 1991, 92, rates of cervical cancer were fairly constant. And then we had organized screening, and we see this very, very large fall, predominantly of the blue line. This dark blue line is squamous cell cancers, which account for about 75, 80% of all cervical cancers. That's by far the most common subtype, followed by adenocarcinoma and adenosquamous carcinomas. So we can see this very precipitous fall in incidence, which then plateaued at around about 6 or 7 cases per 100,000 women per annum. If we look here at the adeno and adenosquamous, we have a very minimal impact, and actually a relative increase in adenocarcinoma from the early to mid 2000s. In the 2-year period, this is before the renewal, so 2014, 2015, just under 4 million women in Australia had a screening pap test, and that equated to an overall participation rate, if you took all women in the country aged between 20 and 69, of 57% of eligible women. Highest in older age group women and lowest for women aged 20 to 24. And that rate's remained relatively stable. I'll show you some more recent figures for WA, which I think are cause for concern. And that's certainly where you, as primary care providers, may be able to have quite an influence. And in 2014, for every 1,000 women in the country screened, there were 8 that had a high-grade abnormality that required treatment. So if we look at participation in the pap smear screening program, this is 2012, 2013, by socioeconomic status, we can see a relatively stepwise increase in participation from the lowest socioeconomic group through to the highest socioeconomic group. And if you look at the incidence of cervical cancer, you would expect the inverse, and that's pretty much what we see. There's a little bit of a blip in the socioeconomic group 4, but certainly the trend is the higher incidence in the lowest groups down to the lower incidence in the highest socioeconomic group. Participation by region. So this is quite interesting. It's pretty constant, actually. There's not vast variations between very remote areas and major urban centres in rates of screening, which, as I say, pretty constant. This is the national average of about 57%. If we look at incidence of cervical cancer, though, there is a stark difference. And we can see that in remote and very remote regions, our incidence is around about 13 per 100,000 women per year, compared to 8 per 100,000 women per year in major centres. So we can ask ourselves, well, if screening rates are equivalent, why is that so different? And if we look at incidence by ethnicity, we can see that our Aboriginal women have over twice the incidence of cervix cancer. It's actually approaching 20 per 100,000 women per year. And this is really an area that we are currently working, and I'll show you a slide later on a project that I hope will have an impact on this. Also, if we look at mortality from cervix cancer, we can see that our Aboriginal women have almost 3 times the death rate from cervical cancer compared to non-Indigenous women. And that may be around later presentation, so presenting with more advanced stage despite participation in screening, but other factors as well. So clearly although our screening program has accounted for a major fall, our incidence is now less than 50% of what it was 20 years ago, we still have work to do. So I'm going to talk a little bit about Gardasil and the vaccination program. This is just a slide to say that it is not a live vaccine, it is a inactive vaccine. It's using the L1 gene codes the protein which covers the capsid. So it's the sort of outer covering of the virus, but it's inactive. So the national program, as I said, currently is for boys and girls aged 12 to 13, part of a school-based program. In 2007, it commenced for girls aged 12 to 13, as well as a catch-up program. And this was GP-based, many of you may remember that. And this was for women up to the age of 26. And that ran from 2007, when the program started, to December 2009. And then in 2013, it was extended to include 12 and 13-year-old boys at school. And last year, we moved from the original vaccine, which was Gardasil 4, to Gardasil 9 as a 2-dose schedule. This is the coverage in boys, and you can see relatively constant. Tasmania actually has the lowest coverage in boys. This is data that's available on the web through the HPV vaccination registry, and in Tasmania, coverage of 64%, with the highest in the Northern Territory, just under 85%. In WA, we're 75% for boys, and in girls, slightly higher levels. So again, nationally, 80%, Northern Territory is 92.5%, and in WA, we're sitting just under 77%. So the impact of the vaccine has been quite startling. The upper box here on the left-hand corner shows the prevalence of HPV subtype 16, 18, 6, and 11. So those were the ones that were covered by the original Gardasil. And we can see a fall from a prevalence of 26.7% to under 7% in the 5 years following the introduction of the vaccination program. So that's quite startling, a 77% fall. You probably all echo this from your own practices. Genital warts were not an uncommon finding pre-2007, and I think we hardly see them today. And as one would expect, and this of course was the hope, that this all translated into a significant reduction of high-grade squamous intraepithelial lesions or pre-cancer precursors. This data was published in 2014, and actually more recent data, which I haven't shown you here, is now falls of high-grade lesions up to about 50%. So that's a dramatic impact. This is just looking at the effect of the vaccination program by age group, and what we can see here is that the program started in 2007. And if we look at women under 20, again, a dramatic fall in HPV prevalence, almost to nothing. And again, mirrored in women aged 20 to 24 because of the catch-up program. But if we look at women in the 30 to 34-year-old age group, we just see that it remains relatively constant, in fact, slightly increased on prior years, because those women were not vaccinated. And I put this slide up, just some useful resources for you around talking to parents. Obviously, what's critical, having showed you the impact of the vaccine, is that we are not victim to anti-vaccine lobbies. And we've seen in Japan in the last couple of years that the vaccination program has been brought to a halt because of an adverse event, which was badly publicised, and the response wasn't rapid enough, and the anti-vaccine movement gained so much momentum that the government had to withdraw the vaccine program, and that would be a complete disaster. So these websites, the National Australian website's very good, but also there's a good web page at MD Anderson, which is a major cancer center in Texas, and the CDC in the US have some very useful ways to actually reassure parents who might be anxious. Questions like, is the vaccine going to make my child more sexually promiscuous? Is the vaccine safe, et cetera, et cetera. So I'm sure many of you know how to answer those sort of questions anyway. Now I just want to talk about secondary prevention, and this again was the impact just purely in terms of the pap smear program that came in the early 1990s. We see a dramatic fall in incidence and a 50% reduction, not just in incidence, but also in mortality. So that's an outstanding success. But it plateaued, and one of the reasons for the renewal was that we're living very much in different times. We know a lot more now about using the HPV test as a primary screening tool from very large randomized control trials internationally, but also with the impact of the vaccine program, it was time to look at our screening program and could we improve on it. And a major effort over several years resulted in the renewal and a new program which started on December the 1st, 2017. So it's coming up for its second anniversary. And as I'm sure you all know, we've now moved to a 5-yearly screening test, which starts at age 25 instead of age 18, with an exit at between 70 and 74. But good for women because the 5-yearly interval results in far fewer screening tests over a woman's lifetime. And it's a very well organized system with invitations to screen, reminders and recalls. We have a national registry for the first time. Previously it was state-based registries, and an expanded quality assurance program. And this move just to primary HPV testing as our primary screening test is anticipated to lead to a further 30% reduction in the incidence and mortality of cervical cancer. And as I'm sure you all know, and I'm not going to dwell on these slides, your screen result basically reports that the woman is either low risk, high risk, or intermediate risk. And if she is high or intermediate risk, then there's a reflex cytology, which is done on the same specimen, which is liquid based now, not using pap smears on glass slides. And then it gives you a recommendation for what action needs to be taken. And I put these here, not going to talk to them because I'm sure you all know this, but they're quite nice looking. And if you want to copy them and just paste them onto your desktops at work, please feel free to do that. And that's what the report for an intermediate slide tells you, and the same for high risk. And these screening pathways are, again, please feel free to paste these onto your desktop. They're a little bit complicated, and I'm not going to talk to them, but I've put this up because it's a very helpful app, which is actually endorsed by the federal government and the cervical screening program. And it's not an app that you can actually put onto your phone, but you access it through a web browser. If you just Google, or if you just paste that link into your web browser, it will take you to ServiScreen. And this is a very easy to use, intuitive process where you just click on if it's an asymptomatic woman and she's screening, very easy to use, and tells you exactly what to do. So again, just to emphasize, 80% of our patients with cervical cancer nationally are women who have never screened or who are underscreened. And we need to do something about this. And I just want to spend 2 minutes talking about self-collected samples, because I think this is a big hope. Obviously, having a speculum examination and a healthcare provider perform that is invasive. And for many women, for a variety of reasons, whether it's previous abuse or just culturally, cultural reasons, these are big barriers. And a self-collected vaginal sample is a perfectly appropriate alternative. It has to be done in the practice, so it's not like bowel cancer screening with a kit at home. It has to be done in a healthcare practice, and it's facilitated either by yourselves or by a practice nurse with a quick explanation of what the woman needs to do. It's only Medicare rebatable to women who are underscreened or never screened and who are over 30. And Medicare are very strict about this. So if it's not used appropriately, then the woman will get a bill. But you can order the kits from, I know you can do it from Pathwest and from Westerns. I'm not sure about other providers. You just need to write on the request form that it's a cervical screening test self-collected. If you're in a remote location, it doesn't matter. You keep the swab at room temperature. It doesn't need to go in the fridge. There's no quality deterioration over several days before it can be flown out. And Pathwest have to send it at the moment interstate because the Victorian Cytology Service and also Sonic Health in Victoria and New South Wales are the only accredited centres to actually process these, but that's paid for. So there's no cost to you for doing that. Pathwest will organise that. And the results are usually about 2 weeks. This is a different pathway, obviously, because if a woman is positive, because there are no cervical cells, this is just from the lower vagina, then she has to be referred for, well, you have to see her to do a cervical sample to get the cytology. And this is just a little bit about, we've recently had some funding, which is excellent news, to do a project which is going to target all women, but particularly aimed at our Aboriginal women, to pilot a one-stop service. So this is a little bit akin to what you heard from Christobel previously, like a triple test. So we have machines which will give us an HPV result in 2 minutes. And so if we can do this opportunistically in underscreened or never screened women, we can get the result, and we can then also have a portable digital colposcope with trained gynecologists or trained help. Doesn't have to be a gynecologist, it can be a nurse that beams the images back to Perth to be interpreted, and if necessary, a biopsy performed that will then confirm. And I think the next step, which will be in future, is actually treating that woman, because we may never see her again. And I think if you can screen a woman once in her life, there's evidence to show that that will actually impact on cervical cancer incidence. If for those of you that are interested, there's a 294-page document, which is the new program. That's available on the web. And the last couple of slides, this is all very exciting. So Australia have really led the way in cervical screening, and we're one of the first countries in the world to use HPV as our primary test. And earlier this year, published in the Lancet Public Health, a very eminent group from New South Wales, including Ian Fraser, who developed the vaccine, published this in the Lancet Public Health. And it's based on modelling, which really shows that cervical cancer in Australia may well disappear from a public health definition. So public health definition is less than 4 per 100,000 cases per year. But I want to emphasize, and that may happen depending on various assumptions in their modeling, that may happen as soon as 2028, actually. But very importantly, the assumptions in this modeling were that the vaccine coverage remains high, and also very importantly that women continue screening, and that 5-yearly screening rates are higher than 90%. And this is really where you play a very important role, because we're nowhere near that screening at the moment. And these are some figures which are not yet published. We've done some data linkage work that we're just submitting for publication, which just shows you screening by various regions. So if we look at the goldfields, participation in screening for eligible women was 42%. If we look at the Pilbara, it's just under 42%. So the total is just under 55% for all these centres combined. But I think this is very concerning, and I think there's a perception still amongst women that once they're vaccinated, they don't need to screen, they're protected. And that is not the case. Even though we've moved to a non-valent vaccine that covers 7 high-risk subtypes now and the 2 that cause genital warts, there are still subtypes which can cause cervical cancer, and if a woman doesn't screen, then that modelling that shows eradication is not going to eventuate. So very, very important. So I'm going to take some questions now on cervical cancer prevention, screening, vaccination, before moving on to the next talk.
All right, so we have a few questions that have come in. The first one is that is early age sexual debut independent of multiple partners? Perhaps the immature cervical epithelium is more vulnerable to infection?
That's a great question. So yes, early age of sexual debut is independent of multiple sexual partners. You just need to have intercourse once, and the possibility of being infected with HPV is high, depending on your partner and depending on whether they've been vaccinated. That's an independent risk factor. And there are actually, in the guidelines, I didn't have time to go into this, there are special populations. And if, for example, you're seeing a woman who's had early sexual debut, then there may be an indication to offer her screening prior to the recommended age of 20.
The second question is, why is HPV vaccination coverage higher for girls? Better school attendance or longer duration of the program?
Again, that's a very, very good question. And I don't know the answer to that. I think possibly longer duration of the program. Also possibly around education. I think it needs time to explain why boys are being offered the vaccine. And that's come out of a lot of research showing a benefit in addition to the herd effect that one gets. So there was a herd effect around HPV prevalence in boys following female vaccination, but there's an additional benefit and sufficient to warrant vaccinating boys in that age range.
And one final question was, until which age can Gardasil be initiated? So
that's a very good question as well. So in fact, last year, the FDA in the United States and also our Therapeutic Goods Administration in Australia increase the age up to 45. So in fact, the guidelines say that women who are less than 46 years of age may be offered vaccination. So I'm now going to spend the next 25 minutes talking about ovarian cancer, very much with a focus on what's relevant to you in primary care, and very much with a focus on screening, and very much with a focus on how do you speak to the asymptomatic woman who's asking for screening, which I think is quite common. Much easier just to accept that and not go into too much detail about why, and to succumb to a request for an ultrasound. But very important in the asymptomatic population not to do that. And so that's really the focus of the talk. And also around diagnosis of ovarian cancer, and particularly using a tool called the Risk of Malignancy Index or algorithm, and how you can use that and how that will help you refer to the appropriate specialist team. A couple of slides on treatment and post-treatment surveillance, but for the sake of time, the emphasis is on those first two topics. So learning objectives, as I've said, discussing screening with patients, how do you manage the woman with a cyst, and then a little bit about treatment and post-treatment surveillance from a general practice perspective. So just a few statistics to give you, to set the scene here. Was estimated last year nationally that there were just over 1,600 new diagnoses of ovarian cancer. And that accounts for a very small percentage of all female cancers, 2.5%. But you'll see that sadly, over 1,000 deaths from ovarian cancer last year, accounting for just over 5% of female cancer deaths. So what that's telling us is that the mortality to case ratio is unacceptably high. Ovarian cancer is a bad disease. 80% of our women are diagnosed with advanced disease. It's already metastasized throughout the abdominal cavity, and almost invariably that is incurable. So in WA, this is older data. This is 5 years old from our cancer registry. There were 142 diagnoses in 2014, and in that year there were just under 1,400. So last year, 1,600, you can say roughly about 160 diagnoses. This is some data that was published in the Medical Journal of Australia in 2014, and it's very, very interesting. What it shows was by state, and I haven't put that data up, but I'll come to state variation in a minute. What it shows us is really what's obvious, that if you're diagnosed with stage 1, this column is 3-year survival, this column is 5-year survival, which is our major oncology metric. So if you're diagnosed with stage 1, you have an 87% probability of being alive at 5 years, so highly curable, slightly less for stage 2. But stage 3, which is about 2/3, 70% of our patients, 31% of those women only were alive, so almost 70% sadly died by 5 years. And stage 4 is even worse here, so almost 90% of women are not alive at 5 years. And in fact, even at 3 years, 80% of those women would sadly be deceased. What's interesting is that if we look at areas of residence, so is there a difference between women with ovarian cancer diagnosed in metropolitan centres versus regional and remote? And there is. It may seem small in percentage terms. So if we look at the 5-year survival, it was 36% for women diagnosed living in metropolitan centres versus 33% in regional and remote. But statistically, in the multivariate model that was fully adjusted, taking into account stage and age and other important prognostic factors, there was a 20% greater chance of not surviving if you lived in a regional or remote centre. So that's 1 in 5 women compared to those living in metropolitan centres. Why that is, I'm not sure. I have some ideas, but these are the sorts of things that we need to really drill down, because we can potentially make an important difference. Now, this is very, very recent. So this was published 2 weeks ago in the Lancet Oncology, which is one of our probably the foremost oncology journal globally. And it was an important piece of work done by IARC, the International Agency for Research in Cancer, which is based in France. And it's called the International Cancer Benchmarking Project. And it was comparing survival for several common solid malignancies across 7 countries with similar healthcare systems. So Denmark, Norway, Australia, New Zealand, Ireland, and 1 or 2 others, that are Canada, which have national health services basically and similar health setups. And some cause for optimism here. So if we look, it looked at survival over a 20-year period from 95 to 2014, but if divided them into 5-year epochs. And if we look at the last period, 2010 to 14, this is for ovarian cancer. Australia actually was 2nd highest survival. So a slightly different metric. This is what's called net survival, not crude survival, which are in the previous figures. But if we look here, 43% 5-year survival, very, very close second to Norway. But compared to Ireland, which had the lowest survival of 36%. But importantly, the message is over time, even in the UK. So in that first period in the UK, there was a 27% 5-year survival. Even that rose to 37%. But generally, the trend was for rising survival over that 20-year time period. This is information that's publicly available on the ICBP IARC website. What's very interesting in Australia is that, and I'm not blowing our own trumpet for WA, because I think we just need to look at the reasons why, but the Australian data was based on 3 states, which all had very good registry data: Victoria, New South Wales, and ourselves. And WA had the highest survival, and we've known that from the previous MJA study. Our survival is significantly higher than Victoria and New South Wales. And again, there's theories as to why that is, and I'm happy to take questions on that at the end. So look, some cause for optimism, but we still need to do a lot better. This is local data from St John of God Hospital. This is a survival curve, which I'm sure many of you will be familiar with. And this is a much smaller group, and it's from a different time period. It's from 2006 to 2010. But pleasingly, in this small number of patients, the 5-year survival was 56%. So more than half of women were alive at 5 years, and this is for all stages. Now, what's important here, this is for women with advanced disease, stage 3C. So that's widespread metastasis confined to the abdomen, a mental mets, liver surface, splenic surface, diaphragmatic disease. And the reason I put this slide up is to make a point. So this line, there are different colors, you can see pale gray, corresponds to surgical outcome. And what we mean by surgical outcome is residual disease at the conclusion of the laparotomy. So R0 is what we strive for. We don't want to see or feel any macroscopic cancer at the conclusion of that debulking operation, because if you're in that group of women, you have a much better prognosis. If you look here, the 5-year survival, substantially better than women who had residual disease, either greater than 1 centimetre or less than 1 centimetre. And even at sort of 40 months, you can see that over 3/4 of those women were alive, versus almost half of women in women that had residual disease. So that is the single most important prognostic factor in ovarian cancer. And you are much more likely as a patient to achieve R0 at your surgery if you're operated on by a gynecologic oncologist. There's abundant data that if you are operated on in a tertiary center by specialists who are doing higher volume surgery for this disease, your outcomes are better. And that's really what's driven care nationally and internationally, and why gynecologic oncology developed as a subspecialty, and why it's really inexcusable to have surgery outside of a tertiary centre, because it compromises your outcome. Just very quickly, when we're talking about ovarian cancer, obviously it's not one disease. And I think this is one of the big problems with screening, and why screening has so far not shown to benefit women. It's multiple diseases. The most common disease is epithelial. Obviously, stromal tumours, germ cell tumours are much less common. And the most common epithelial tumour is high-grade serous. High-grade serous accounts for 70% of epithelial tumours and about 60% of all ovarian cancers. And it accounts for most deaths due to the disease. This is the silent killer. And I just wanted to spend a couple of minutes on more recent, not really hypotheses anymore, actually sort of proven mechanisms of pathogenesis. And I do this because it's one of the reasons why I think screening has yet to be shown to benefit women in terms of mortality reduction. So this is a hypothesis which is decades old now, called the incessant ovulation hypothesis. And this is the ovary, this is the fallopian tube. Ovarian cancer, and some ovarian cancers do start this way, but not high-grade serous, or not most high-grade serous. So the tumour thought to arise within a cortical inclusion cyst close to the epithelial surface, malignant process. The cancer then migrates to the epithelial surface and metastasizes because the ovary is open to the peritoneal cavity, it's exposed. And you get metastatic cancer wafting around the abdomen because you've got circulation of physiologic fluid, but metastasis on the tube, metastasis anywhere. Now, women who, the BRCA gene was discovered in the early 90s, cloned in 1994, and then by the late 90s, women with bad family histories of breast and ovarian cancer were being tested for BRCA mutations, and those that were discovered to carry the gene fault were offered risk-reducing surgery. And for the first time, pathologists, when they looked at fallopian tubes from these women, noticed the precursor. So this is the equivalent of CIN in the cervix. This is a normal H&E stain of a normal appearing fallopian tube. You can see here a single layer columnar epithelium, normal appearing nuclei, underlying stroma. This is abnormal. This is what's called the P53 signature. This is the first event in ovarian cancer genesis. A mutation, usually loss of function, sometimes gain of function mutations in P53, which, as you'll all remember from medical school, is a very important tumor suppressor that controls cell cycle regulation and cell division. And this is a P53 stain. It's an immunohistochemical stain that in normal tissue is negative. In tissue where you've lost P53 function, you get this dark brown stain. And over time, what happens is you get progression to the malignant precursor. This is not normal. You can appreciate it's multi-layer, very abnormal nuclei, mitoses. That is 2 to 3 years away from becoming malignant, which is here. It's called tubal intraepithelial carcinoma, or serous tubal intraepithelial carcinoma, because it's secretory. And serous tubal intraepithelial carcinoma, known as a STIC, is the acronym. So STIC lesions are now proven to be the precursor to high-grade serous cancer. So it's tubal, it's not ovarian. And this is the redrawn diagram where this is our normal tube, this is our STIC or precursor, our cancer metastasizing. And of course, because the tube physiologically adheres to the ovary, which is what it does at ovulation to pick up the egg, it's in very close proximity. By the time we see it as a cancer on ultrasound, it's just a solid mass. We didn't really appreciate that it was coming from the fallopian tube. So this is no longer a hypothesis. This is really the mechanism for the majority of high-grade serous cancers. Not 100%, but most. And important as to why screening, I think, so far has failed. So what are our screening tests? As you all know, a blood test for CA125, a transvaginal ultrasound. The ultrasound, CA125 is just a glycoprotein that's secreted normally by the peritoneum. And it's elevated at anything that causes peritoneal inflammation. But it's very non-specific. There are a whole host of diseases, benign and malignant, which can put it up, including menstruation. Ultrasound looks at morphology. It's good at detecting abnormal morphology, but it's very, very poor at distinguishing between benign and malignant changes. You can combine them, and this is what's been done in very large clinical trials. So you can increase the sensitivity and the specificity and the positive predictive value if you combine them. And you can do this in sequence, so you can use CA125 as the primary test, And if that's abnormal, you can then triage to a secondary screening test such as an ultrasound. The ROCA, risk of ovarian cancer algorithm, is a test which is a little bit different. So it doesn't use an absolute cutoff or a single CA125. It uses changes over time to inform the secondary test, which is a transvaginal ultrasound. And this is the largest trial ever done in medicine, let alone in gynecologic cancer. This trial is the biggest RCT ever in the history of medicine, which was the United Kingdom collaborative trial of ovarian cancer screening, or UKC-TOX. And UKC-TOX recruited over 200,000 women from the early 2000s, I think 2001 to 2005, and it followed them, and it's still following them today. And it was the great hope, and it reported its primary outcome in 2015, December 2015. And this is the main result, which unfortunately didn't show a significant difference in mortality. That was its primary endpoint, deaths due to ovarian cancer. And it randomized women, 100,000 or 101,000 women were randomized to no screening, just routine care. These were women aged between 50 and 70 in the United Kingdom at multiple sites. It randomized the other 100,000 women to ultrasound only, or to what was called multimodal screening, which was what I was talking about before, which was the ROCA blood test, serial changes in CA125, which then triaged women to ultrasound if there was an abnormality. And the primary endpoint for mortality was not significant. You can see a slight division in the curve here. So the y-axis is mortality per 100,000 women per year, and the blue curve was the control group, no screening, and these were the screening arms. And you can see a slight separation, but that did not achieve significance. The p-value was 0.21. However, I don't want to be too pessimistic, and the lead investigators of this trial are optimistic. They did a sub-analysis which excluded prevalent cases. So what they said was, well, it's not correct to include women who are diagnosed at their first screen, because when you start the program, you're going to pick up some women that already have ovarian cancer. So they excluded those women. And if you do that, then at about year 7, the curves actually start to separate. And by year 14, they're actually wider. And this was significantly different. So if you compare women who had no screening to women who were in the multimodal screening, then the difference became significant on analysis. This trial has been very controversial, and there was a lot of very toxic letters flying backwards and forwards in the literature because some people disagreed with excluding prevalent cases, and I'm happy to talk about that either at the end or offline as to why one should or shouldn't. But they also used a different statistical test, which they hadn't pre-specified. And they excluded primary peritoneal cancer as well. And so at the moment, we cannot say unequivocally that screening reduces mortality. And that's informed a position statement, and I'm not going to talk too much about this, but I would definitely refer you to it. That's the link. Cancer Australia came out with this earlier this year. It's a very evidence-based, I think very tempered and well-written guideline. And the key point is that for asymptomatic women in Australia at the moment, we should not be offering any sort of screening because really the capacity to do harm is higher than the capacity to save lives. And this applies to low-risk women. It also applies to high-risk women. So if you carry a BRCA mutation, your lifetime risk of ovarian cancer is substantially higher than the population risk. The population risk is 1.4, 1.5% lifetime, which is actually low. If you have a BRCA1 mutation, you might have a lifetime risk approaching 50%. But even for those women, we should not be offering them screening. The only evidence-based approach that reduces their risk of ovarian cancer currently is surgery, risk-reducing bilateral salpingo-oophorectomy. And you should refer any woman who is either high risk, known to be high risk, or who is potentially high risk because of a family history of ovarian cancer. That is the single most important risk factor. They should be referred for genetic assessment. And this is just a plug for a research study that we're involved with in Western Australia called TraceBack. TraceBack is about identifying women who would merit from genetic testing. And these are women who've either had ovarian cancer and not been offered it. And I hope now in 2019, all your patients that you look after with ovarian cancer would have been tested. There may be one or two, So please, if you see them, ask them if they've been tested for genetic conditions like BRCA. If they haven't, they can self-refer, and there's the number, and it's free. If one of your patients has a relative, like a mother or sister or aunt that's died of ovarian cancer, they may be eligible for free, and they can self-refer to that free phone number, and they will be offered testing if appropriate. So really, to the nuts and bolts of this talk, what do you say to the woman who's asymptomatic but asking you for an ultrasound because she's had a friend that's just died of ovarian cancer, or she's had a mother that died of ovarian cancer, and she's anxious? So these are just some points, thoughts of mine. This is what I would discuss with a woman. I would say to her that any screening test before we offer it needs to identify most women with the disease. That's sensitivity. And at the moment, our tests don't do that. Very importantly, a woman who has a positive screen result, most of those women should have ovarian cancer. In other words, there should be a low false positive rate, and a positive result should have a high positive predictive value. And this is very important in this situation, because a positive test is probably almost certainly going to lead to surgical removal of that woman's ovaries. And if she's premenopausal, that can cause harm because she's going to go through a surgical menopause, and it may cause an unnecessary surgical complication. So very, very important to mention this. No test or combination of tests at the moment meets those criteria. It also may provide false reassurance, and the reason it may provide false reassurance is that a normal ultrasound doesn't tell us whether there's that microscopic precursor sitting in the tube waiting to explode. Sadly, in our practice, we've all seen women who carry BRCA mutations that are not quite ready, despite advice, to commit to risk-reducing surgery. In the old days, we did used to screen them with ultrasounds or perform surveillance and CA125, but we don't anymore because the guidelines and the evidence tell us not to do that. And I think in that situation, ultrasounds may cause harm because they provide false reassurance, and we've all seen patients come back 6 months later with full-blown stage 3 ovarian cancer, which is then incurable. So even the highest sensitivity, which is ROCA, which is that combination of serial change over time and then ultrasound, the maximum sensitivity is 84%, so it's going to miss 16% of cases. Specificity of ROCA is better, but the false positive rate is still 3 cases per cancer detected. That's actually pretty good. An ultrasound by itself, you need to do 15 of those in an asymptomatic woman to pick up 1 ovarian cancer. That's 15 surgeries, which are, 14 of those surgeries are going to be unnecessary. And most importantly, we have no evidence that screening reduces mortality. Now, I've emphasized that enough. It's worth having that discussion, I think, rather than caving into the woman's request, if she's asymptomatic. If she thinks she's high risk, please refer her for assessment. Totally, totally different to the symptomatic woman. And this is really important, because we frequently hear, I do a lot of consumer engagement and talks or at survivor forums. And what I constantly hear from patients is that there was a long, long delay in them getting their diagnosis, months, because they were investigated for other conditions such as irritable bowel. So these symptoms, particularly the 4 that are in bold, bloating or increased girth, abdominal or pelvic pain, early fullness, and urinary symptoms, particularly in combination, and particularly if they've lasted more than 4 weeks, must be investigated. So please remember those, and do not be afraid to investigate those women. That really is totally different to the asymptomatic women. You're not screening those women, you're investigating the symptomatic women. So that's critical. And I put this up because it's a fantastic guideline. I don't know if you are aware of this, but Cancer Council and Conjunction with Cancer Australia have developed a very, very good care pathway, optimal care pathways for all sorts of cancers, but there's one for ovarian cancer, and there's the web link. There's actually an abbreviated version for general practitioners. It's very, very good. It's comprehensive, and it doesn't take long to read. You can download it for free to your desktop. And there's also a patient guide, which you can download and give the patient or give them the link. And that's all the information on that slide, and I'd encourage you to read that. Now, the optimal care pathway says that, just what I've said really, that symptoms for more than 4 weeks need to be investigated. If you think it's something else and they're not responding to treatment within 2 weeks, they should come back and be investigated further. And that the examinations need to include a physical examination, including a pelvic exam, preferably a transvaginal ultrasound by a provider that's experienced, the use of the RMI, which I'll talk about in a moment, and a routine set of blood tests, full blood count, obviously liver function, coags, renal function and electrolytes, and a CA125, and a CT if appropriate. And that the woman results need to be available within a week and reviewed by yourselves within a week. And timeframes for referral, again, there's no real evidence to guide this, but I think if there's any concern based on those investigations that they need to be seen within 2 weeks. And I'm not sure that's happening, and we need to work harder and smarter to ensure that that does happen. Just a couple of slides about really your role, because I think you do play a vital role in this pathway, both in terms of diagnosis, also in terms of arranging referral, but also coordinating and being involved in care following treatment and providing support to the woman and her family. And particularly support whilst they're waiting for the appointment. It's a highly stressful time, obviously, before they get seen. Now, risk of malignancy index, it sounds complicated, it's not. It relies on 3 things: the woman's age, she's given a menopausal score based on her age and menopausal status, the CA125 level, and the ultrasound report. And I'll tell you how to calculate it, but you basically multiply each of those 3 scores. A score of more than 200, the woman needs to be seen by a gynecologic oncology centre. It's quite sensitive. Its value lies in its negative predictive value, so it's quite specific. And let's just come on to it. I've got a case history, but basically the ultrasound, you score 1 point for each of these 5 features. So if there's a multilocular cyst, that's 1 point. Solid areas within the cyst, that's a point. If there's obvious mets, that's a point. Acidic fluid, that's a point, and bilateral masses. Now, there's 3 scores that the ultrasound can give you. Either 0 if it's completely benign. That would just be a fluid-filled cyst with no locules. 1 point for any one of these features is 1, and if there's more than 1, the score is 3. So this is a 60-year-old woman that you've seen. She comes with 4 weeks of pelvic pain and bloating. So that's an alarm bell. You've organised a pelvic scan and you've organised a CA125. And it's only mildly elevated. It's 50, but it's above the upper limit of normal of 35. This is the scan. So what we can see from the scan is you've got black is fluid and white is solid. So you can see very nicely, this is the ovary. And you can see very nicely fluid areas and solid loculations. These are fibrous bands. There's one finer one here. There's a solid area here. That's like a sort of papillary projections. So she's got multiloculated and she's got solid area. So that's 2 features. So her ultrasound score is 3. And she's 60, so she's postmenopausal. Now, the menopause score, you're 1 if you're premenopausal and 3 if you're postmenopausal. If you've had a hysterectomy and you're not quite sure if she's over 50, but she had a hysterectomy at 45 and she was having period at that stage, you give her a score of 3 to be on the safe side. So that woman's score is going to be, if we just go back, no, don't worry, I think I've calculated it actually, but her score would be 3 for the ultrasound, 3 because she's 60, that's 9, and you multiply 9 by the CA125 absolute value. So 9 by 50 is 450. So her score is over 200 and she needs to be seen by a gynae oncology unit. It still may be benign, but as I say, the value in this is the negative predictive value. So a score of less than 200, there's only a 5% chance that's malignant, or a 1 in 20 chance. And that means that you can refer her to a general gynecology clinic, but if you're in doubt, you can always pick up the phone or always send it through to the gynae oncology clinic to us, and we can have a look and then triage that ourselves and calculate that score ourselves. Okay, and that's the score from the case. Sorry, I was jumping ahead, but that's how you calculate it. So it's pretty straightforward, an easy thing to do. So just the last couple of slides. Treatment is always usually a combination of surgery and chemotherapy. Very, very rarely it might just be surgery, and that would be for an early stage tumour that's usually diagnosed incidentally following surgery for what was thought to be a benign cyst. And for low-grade cancers, even early stage high-grade tumours, we would often recommend chemo. But as I say, 80% of our patients are diagnosed with advanced disease, stage 3 and 4, and they would have pretty major debulking surgery followed by adjuvant chemo. There's been a big adoption now of neoadjuvant chemotherapy, so giving 3 or 4 cycles prior to surgery because it downsizes the tumour, then operating and then following with more chemo. And I think within a year or two, half of our patients are then going to be on what's called maintenance therapy. This class of drug, PARP inhibitors, you'll hear more and more about. You'll probably see patients on them. These are tablets which have been shown to be very beneficial in some women with ovarian cancer, particularly high-grade serous cancer, where they carry BRCA mutations. And this is a slide from a paper which is now a year old. It was published in the New England Journal. These were women who had BRCA mutations and advanced ovarian cancer, and they were randomized to a placebo, which is the red line, or to the tablet. So they all had the same treatment. They all had surgery followed by standard platinum-based chemo. But after the chemo, they went onto the tablet. This is the olaparib, or to the placebo. And this is, we've never seen anything like this in ovarian cancer. This is out to 5 years. And you can see that the women randomized to the active drug, at 5 years, less than half of these women had relapsed. The primary outcome in this study was relapse, not death. So this is extraordinary. And women now, the drug is available. It's going through TGA at the moment. A lot of our patients will be on this after first-line therapy. And it's going to be expanded to women who are not just BRCA carriers. As I say, there'll be about half our patients who'll benefit from this. So that's a major change in ovarian cancer practice. And just finally, survivorship, because it's very important. I think this is where you have a highly important role in primary care. It's really about preventing new cancers, surveillance for recurrence, screening for treatment-related effects, and also psychosocial effects. And this is a cohort of women who have major morbidity in terms of psychosocial morbidity, fear of recurrence, anxiety and depression, and interventions to deal with those. And I think coordination of care between all providers to ensure that the woman's needs are met are something we probably don't do very well in our tertiary centres, and I don't think we coordinate care very well between our tertiary centre and yourselves in primary care. And that's just a slide on our common follow-up regime. We see patients every 3 months for 2 years, then we usually see them 6 monthly. And it's ongoing 6 monthly. And if they get to 5 years, which, as I say, more than half our patients don't, very sadly, we would then see them for an annual review with a serum CA-125 prior to each visit. And in the follow-up setting, serum CA-125 is much more sensitive to diagnose recurrence. Final slide is just about patient-reported outcomes, because you'll hear more and more about this. This is a tool that's used in ovarian cancer in research, actually, in chemotherapy trials, called the MOST, Measure of Ovarian Cancer Symptoms and Treatment. And it's very quick for patients to fill out. They do it in the clinic. It takes 5 minutes, and it covers treatment-related symptoms, but also symptoms that may flag recurrence. And it covers emotional well-being, physical well-being, and specific things like loss of appetite, peripheral neuropathy, anxiety, depression, trouble concentrating. It's been validated in a research setting. And I mention it because we've just recently received funding to do a large randomized control trial, which is going to use this as a follow-up tool, but randomizing patients to nurse-led follow-up, not to clinic follow-up, particularly for our regional patients who have to travel long distances. There's a huge burden for those women, and I think follow-up's not very structured. They may see a different doctor every time they come to clinic, and they may get asked some of these questions, they may not. And so we need to improve our follow-up, to improve care of the women and their families, to refer them for treatments that may help them. But you'll hear a lot more about PROs, or patient-reported outcomes, because they're going to be rolled out, I think, across a whole range of cancers and other chronic diseases, and will play a very important role in improving outcomes for women.
Thank you for that very comprehensive presentation. Really fantastic. So we have one question here from Rosalie again. How often are they screening in UK CTOS?
So screening in UK CTOS was yearly. So women had a yearly blood test if they were randomized to the ROCKER arm, yearly CA-125. Depending on what that result was, then determined how frequently they either came back. There were categories of low risk, in other words, screen again in 12 months, versus intermediate risk, which was repeat the test in 6 weeks, versus high risk, progress on and have a transvaginal ultrasound, and then depending on the findings of the ultrasound, dictated what happened next. If they were randomized to the ultrasound arm, it was a yearly ultrasound only.
Right, thank you.
Yeah.
If there's no other questions coming in, we'll probably wrap up for tonight. Again, thank you all so much for joining us today, and thank you to both our presenters.
Just wanted to say, if anyone does have a question or would like any information, please feel free to contact me on that email address. I'm very happy to correspond. And I'd like to thank Cancer Council for the invitation, and thank you very much for your attention and for dialing in.
Thank you so much. And also, if you'd like to get in touch with Dr. Christobel as well, you can get in touch with the Cancer Council GP Education program. So that's all for tonight. Thank you again for joining us, and we'll see you at the next event. Thanks.